Okay, hello everybody. We're back talking about EKGs. This is part 2 of chapter 11. I did add a few more slides. It's kind of a merged PowerPoint. So I just want to briefly tell you what this week's going to look like. I will go ahead and also add an announcement, but I've had a couple different PowerPoints that I've sort of merged together, but then I've had to kind of break them apart again so that I could have decent size files so that we can get these onto YouTube and get them all uploaded. So you'll be starting for this week Tuesday. You have day 8. Okay, so and then what else is assigned then today is that MRE. That MRE is not timed, but it is due on Tuesday the 28th. That's MRE 2. Oh my goodness. Then day 9 we will look at ventricular rhythms and idioventricular rhythms. So that's about a 35 or so slide PowerPoint. So that'll be day 9, along with taking exam 1, which is timed. Okay, so don't be trying to figure out open notes. You do have some of your calculations on there, a couple problems with your finding your CaO2, your PaO2, your alveolar air equation, your shunts, your Cc, your Cv. So be prepared for that. You have a couple of those. I don't care if you use your calculator, just show your work. I mean, it's on that crazy blackboard, so you know how weird that is to upload. If it works out, if you can just type your numbers in and label what they are, that would be helpful for the grading process. I'm not sure how that's going to look because it's like a problem or a short answer or something type of format. We have to pick different ways that we upload these problems. Everything else is multiple choice, so that's pretty straightforward. If I have any trouble with seeing the last bit of that with those equations, you can always send it to me as a separate document in an email or whatever, but hopefully just type it all in and I'll probably have to just manually grade it. And then Friday is May 1st, which is day 10, and that'll be a fairly short one with heart blocks. I know I have heart blocks kind of on 2 days, but I've kind of taken out some stuff and added it to some of the other ones, and it's just strictly pretty much heart blocks, so it's a little bit shorter. And then looks like next week then your final will be on Thursday. So Tuesday and Wednesday we'll probably have some, I've got a Jeopardy on there that you can look at for a review. I'll probably have you do another review type of document that you'll have to submit for points. That'll be required for for the final review. And I'll think of some other things. So, all right, enough of that. So let's get moving with this PowerPoint. So as always, email me with questions. Oh, well, and plus, hold on before I forget, you'll also have another exam. So you'll probably, hold on one second. So we've got exam one slotted for, what did I say, Wednesday? So you'll probably, you'll have another exam on Tuesday then. Okay, so you'll have exam 2 on Tuesday. All right, so you'll have plenty to do. All right, so moving forward. Just want to start off with this slide again as just kind of a basic review of the EKG waveform. Okay, so again, your P wave, you should know by now, hopefully from the previous lecture, your P wave is your atrial depolarization. Okay, so when your atrium are contracting. Okay, so that's your blip from your atrial squeeze basically. And then your QRS then is your ventricular depolarization, so then your ventricles are contracting. Your T wave represents your ventricular repolarization, so it's kind of like your little resting kind of part there. Your ST segment then is considered isoelectric. Isoelectric. So no electrical activity. That's kind of just your baseline. Okay. Your PR interval, looking at that, is the time it takes for the impulse to conduct through the AV node to the ventricles, and that is generally less than 0.2 seconds. Okay, so it's really basically the start of the P wave to the beginning of the QRS. Okay, that's the PR interval. You might also see it as PRI. Okay. So keeping in mind that an upward deflection is seen on the ECG or EKG when the axis is flowing towards a positive electrode, and then the downward deflection is when the axis travels towards the negative electrode. Okay, so that's where that little blip is there right before that ST segment. Okay, and I hope you found the videos helpful too from the last PowerPoint that well, they weren't on my PowerPoint, but they were on day 7 under your course content. I sure hope you looked at those. If you haven't, please do. Alright, so when we're looking at our EKG, it's kind of helping us evaluate the patient's overall condition. Okay, there should be some different signs and symptoms that might help us identify if there's any dysrhythmia. Okay, so we're looking at kind of like 3 different levels of what's going on. What type of ventricular response we have to the atrium contracting, the origin of the impulse, and the electrical physiology. If we're looking for any ectopic beats or rhythms, any escape beats or rhythms, any blocks or bundle branch blocks. Okay, so we always look at the EKG as we're reading it left to right. Alright, so there's kind of a systematic method. This is kind of a longer version. This actually comes straight out of Wilkins. But if you look at your Beasley book, your kind of burgundy rust colored EKG book, it pretty much covers like the first 5, right? So you're looking at identifying the heart rate, kind of, seeing if it's, Brady, remember less than 60, or greater than 100 being tachy. Okay, so we're just kind of, and that helps determine if it's a bradycardic, it could be an idioventricular, junctional escape, or something like that, which we'll talk about more. Not so much today, but in the coming days. We're looking to see if it's evaluating the rhythms, we're interpreting it mainly at that point, is it regular or is it irregular? We're noticing if there's a presence of P waves, because remember P waves determines the site of origin, okay, where the first impulse has come from. So your atrial rate is your P waves, and then your ventricular rate is your QRS. And that's why when we say looking at P waves, the other thing you look at is there a QRS for every P wave, or is there a P wave for every QRS? Okay, and that kind of comes into play a little bit more when you're looking at the different blocks and stuff. Looking at the measure of the PR interval, again having to do with the blocks or any type of delay, and then measuring the width of the QRS complex. Okay, just a little side note on, and then of course looking at the ST segment and all leads, especially if you're looking for an elevation or depression to see if there's an infarction, and we'll talk more about that when we talk about chest pain and that. So in cor pulmonale, right atrial enlargement is common, so the EKG is going to show that with a tall, narrow P wave in leads 1, 3, and AV foot or AVF. I know that one guy says AV foot. In the one lecture, it's kind of like a ground lead. Keeping in mind that a normal P wave really should be less than 3 millimeters in height. So 3 millimeters is 3 small little small squares. Okay. All right. So this is just kind of a little summary of the normal values as far as heart rate, and then your PR interval, your QRS interval, your IST segment, whether it's elevated or depressed, and then your T wave. Okay, so kind of showing like if there's some irregularities, what those might be. So this comes from chapter 11, right out of your textbook. So know this table. All right. So consistency is definitely key when you're looking at an EKG. Okay, so you obviously want to look at your patient, kind of get the clinical picture, see what's going on with them. You know, a little background information is always helpful. Remembering that we're treating the patient, not the monitor. Okay, so don't always believe the monitor immediately. Look at your patient, make sure there isn't anything disconnected on your leads, or it's connected up wrong for some reason. So again, you're reading from left to right. Avoid any shortcuts. Know the parameters for arrhythmias, and using that 5-step approach, which is your heart rate, heart rhythm, your P waves, if they're present, your P to R interval, and your QRS complex. Now again, if you view this PowerPoint in the regular format of when we do it in class, you should be able to see the notes that are on the bottom here. All right. Moving on to get the right mouse. I've got 2 computers going here. Sorry about that. There we go. All right. So the heart rate. Again, we're looking at the atrial rate and the ventricular rate. Okay. So you can use the 6-second method. So you would basically count the number of QRS complexes in a 6-second strip and multiply it by 6. Okay, keeping in mind again your normal heart rate between 60 and 100. Less than 60 is considered bradycardic. Greater than 100 is tachycardic. Okay. Again, how is your patient? How are they looking? All right. Now we are looking at our heart rhythm. Okay, so here we're looking to see if it's regular or not. Okay, we're looking to see if the heart rate is regular. So we're looking at the consistency of the beating. Intervals that vary within like 0.0 seconds is normal. Anything more than that is considered to be irregular rhythm. So rhythms are classified as regular or irregular, and you look at the distance between the R to R. Okay, so the spikes, the R to R distance in between them. So even if you don't have a calipers, which is something that they have in the tele room when the teletechs are actually sitting there and just watching all these heart rates, you can just even take a piece of paper and just mark the spike on the edge of the paper, and then the next one, and then you have that, and just kind of march it out and see if that's equal distance every time. Okay, so that's one way of looking at it. So you're looking at, so remember, if you're looking at the R's, you're looking at the ventricular rate, and then if you're looking at the P waves, you're looking at atrial rate, right? Okay. All right, so this is kind of a terminology here that can get kind of confusing, and I think that Banner ECG study guide definitely can help you with this too. But there's the terminology of regularly irregular, or occasionally irregular, or irregularly irregular. I just remember one of the first times I taught this class, a group of girls that I was teaching, that threw them for a loop. They hated that terminology. I always have to laugh when I think back at them. So regularly irregular means that the irregular rhythm occurs in a pattern. Okay, so whatever it is, it's happening again and again. Okay, so so rhythms that are irregular in a pattern. Okay, occasional irregular is only 1 or 2 R to R intervals are uneven. Okay, so it might just be like a little blip. Okay, and then irregularly irregular would be where your RRs have no similarity, and that's more like an AFib. Okay, so like a flutter, especially if you have a 2-to-1 or a 3-to-1, and what that means is that you have one QRS for every like 3 P waves or something, and then you have 3 P waves and then 1 QRS, 3 P waves and 1 QRS. So that's regularly irregular. Okay. So take a look at that banner study guide. I believe that was posted on day 7, and that should also help you. And then this is again kind of showing a different box, like looking at the big box method of determining your heart rate. So you have, let's say you have the big box there. So you have 300 is if your rate is, hold on one second. Okay, so I know I mentioned that in Beasley it helps, there's a couple pages in there that kind of can help you figure out what this different ways of figuring out the heart rate. So the R to R interval, that's the large box method, and that's kind of what this is referring to. So you find the R wave on the heavy line of the strip, and then you count the number of large boxes that are between the first R wave and the second R wave. Okay, so if there are 3 large boxes between the first R wave and the second R wave, like for example, if you look at number 3, then if you go up to the top with the number 3 by the black number 3s, then you would take 300 divided by 3, and that would give you 100 beats per minute. Okay, if there's only 2 large boxes between the 2 R waves, and it's 300 divided by 2, so then your heart rate would be 150. And then if you go the other way, if you're taking it 300 divided by 4, then your heart rate's going to be 75. So that's kind of what that's basically showing there. Alright, so again, the P wave is showing when the left and right atria are depolarizing. Again, a normal P wave is generally less than, well, this says 2.5, but it's 2.5 to 3 millimeters. Always keep in mind there's a little bit of a range, and I know that really frustrates a lot of you, but it's just kind of the way it is. It depends on which textbook. Okay, so if it's like grossly abnormal, I guess. This actually should say less. The P wave should last less than 0.10 second. I need to go in there and change that. I have that on my notes. 0.10 second there. Okay, so looking for any odd shape, it might indicate atrial enlargement. Okay, so you should be asking yourself, are the P waves normal? P waves should be rounded and upright. Okay, meaning positive. So are there P waves present? If not, then the rhythm isn't coming from the atria. Okay, so if you don't have any P waves, the rhythm is not originating from the atria. Are the P waves occurring regularly? If not, some of the beats then are coming from someplace else. Are the P waves smooth, round, and upright? If not, there may be something wrong with the atria, or the rhythm may not be generated from the SA node. It might be coming from the AV node instead. Again, if you view this PowerPoint in the format where you can see the speaker notes, these are all on there. Do all the P waves look the same? If they don't, maybe some may be generating from someplace else other than the SA node. And is there a P wave for every QRS complex? If not, again, it might not be coming from the atria, or sometimes the P waves are buried or hidden, especially in more tachycardias, fast heart rates. Alright, so if the SA node is firing regularly, then the P wave should be regular, and then you would have a sinus rhythm. Okay, so sinus if everything looks good, it looks normal, the SA node is firing regularly, the P wave should be regular, and then that's considered a sinus rhythm, okay, because it's coming from the SA node, sinoatrial node. All right, now looking, I'll try not to spend several minutes on each slide. It's 45 slides. All right, so now we're looking at the P to R interval. That's the time between atrial depolarization and ventricular repolarization. This represents that delay through the AV node, and there should be a slight delay, but if you have a prolonged delay, then you need to kind of see what's going on, okay? So moving on to the next slide here. So this is kind of a real blown up version of the P to R interval. So you're measuring from the beginning of the P wave to the onset of the Q wave. A normal should be, the P to R, 0.12 to 0.2 seconds. Okay, so that's the P to R. That's a normal. So that's about 3 to 5 small squares or so. Okay, so about 3 to 5 small squares is a normal P to R. If you have a shorter one, less than 0.12 seconds, you'll see that more so in a tachycardia. Then if you have a prolonged P to R, like over 0.20 seconds, you have a delay in the conduction system, okay? So that's probably an AV block, okay? An analogy here is if you shoot a gun and there's no velocity behind the bullet, it won't do any good. It's the speed that allows it to cause any damage, okay? And we'll talk, I have like a little poem to kind of help you remember the heart block, so don't worry about that. Alright, so this is again kind of just showing a little bit more of a different view of your P to R interval. You also could have a fat P wave with lung disease, okay? Not necessarily though a change in your P to R interval. Okay, so we're just looking to see if they're consistent and if the P to R is between 0.12 and 0.2 seconds. Alright, now we look moving on to the QRS complex. And our QRS complex is representing ventricular depolarization. Okay, it's normally less than 0.12 seconds. If you have a wide QRS or kind of a fat QRS, which is then greater than 0.12 seconds, you could be indicating an electrical imbalance. It could also be just a PVC or a bundle branch block. Okay. Let's see. So we also have to look to see if that Q wave part does have that little tiny blip of a first negative deflection. So if we're really kind of analyzing each part of the QRS, okay. The R wave then is your first positive deflection, is the tallest part of the waveform. And then your S wave is your sharp negative deflection following your R. Okay, and then there's a thing called the J point. I don't really remember having any big questions or anything about the J point. I'm just going to tell you a little bit about it. The J point is the portion of the EKG tracing where the QRS basically ends and the ST segment begins. And then you also have something called the QT interval. Okay, so that's encompassing there. You can see the beginning from the QRS all the way to the T. So it also could be called the QTI, the QT interval. Represents the refractory period of the ventricles. The QT interval represents the total ventricular activity as they depolarize and repolarize. The QTI is directly related to the heart rate. Okay, so this is kind of showing you more of a normal QRS, again being less than 0.12 seconds. So these are different questions that you kind of ask yourself. Are the QRS complexes similar in appearance? Are they greater than 0.12 seconds, are they fat? Again, QRS complexes can look different from patient to patient. Not all can look identical. Alright, so a few more things to kind of consider here is your ST segment. So your ST segment represents the early beginning of ventricular repolarization. Okay, so that's after the ventricular depolarization. Your ST segment is kind of the point where the ventricles are repolarizing. So that's being measured from the end of the QRS to the onset of the T wave. Usually it's consistent with an isoelectric line, meaning it should just be kind of straight. Okay, it should just be flat. Okay, so you want to kind of watch again for elevation or depression, because that could be an indication of an MI. And we'll talk more about that here in just a minute. Oh, right now actually, because I'm just looking at some of my notes here. So again, your T wave can sometimes vary. You could have a high or a tall T wave that could represent electrolyte imbalance. So an ST depression, okay, so going down is ischemia. So if that ST line is not isoelectric and it kind of is depressed, it goes below the isoelectric line, then it's more indicative of ischemia, which is not as bad as an elevation. An elevation is an MI, myocardial infarction. Okay, so think of, I don't know, I have all these weird ways of remembering things, but so if you have the an MI infarction elevated, I think that you're going up to maybe a different life. I don't know. It's just kind of one way of looking at it. So an elevation would be worse. Okay. Also there on that small picture there with the muscle tremors, that's kind of what artifact can look like. Patient moving, you know, the alarms go off sometimes and it's just somebody moving in bed, loose electrode, improper grounding. So again, look at your patient before you get all freaked out. What else was I going to say about that? Oh, if you're doing chest PT, either the old-fashioned way or with a percussor, that can also cause artifact like that. So sometimes that gets the nurses a little bit excited when you come into the room, and they come running into the room because they're seeing that in the monitor. It's just you. It's your fault. My fault. All right, sinus rhythm. Okay. So let's see. I'm gonna see where I have my notes here. All right. So normal sinus rhythms. This is not normal sinus rhythm. So these are rhythms that originate from the SA node, are considered sinus rhythms. Okay, so from the sinus node. That's where they're supposed to originate from. Versus the AV node. Alright, so here is where you can see where normal sinus rhythm can definitely look a little bit different depending on the patient. So we're looking here to see if it's too fast or if it's too slow. This heart rate looks like to be about 60. I don't know where the slide came from. Looks like it was on this PowerPoint when I started teaching this class, so I did not violate any HIPAA, just FYI. Looks like it's from like April of 2002, 15 years ago. So here's an example. We're asking ourselves then, is there a P wave for every QRS? Yes, there is. Is the rhythm consistent? Do the QRS complexes look normal? So you can see in lead 1 and lead 2. So the Roman numeral 2 is the one that they most likely look at. Those are the kind of more common leads that they interpret the EKGs for most things. Are all segments where they should be? Is the PDR interval between 0.12 and 0.2 seconds? And is the QRS less than 0.2 seconds? 0.12 seconds. Okay. Now we have a little bit of sinus Brady going on here. Okay, so this is telling me here, if I had a 6-second strip, assuming this was a 6-second strip here, I could kind of guesstimate that this heart rate's about 40. Okay, because I've got 4 QRS complexes. Okay, so my rate's definitely less than 60. My rhythm is regular. I have P waves followed by every QRS. My P to R interval is normal, and my QRS is normal. Okay, so some of the different things that can cause sinus Brady can be beta blockers, SA node disease, calcium channel blockers, vomiting, hypoxia, hypothermia, an inferior MI, sometimes sleep, and well-conditioned athletes. So it could have many different causes. Again, look at your patient. Are they symptomatic? How is their blood pressure? Okay. So vomiting, hypoxia, hypothermia, inferior MI, inferior wall MI. Again, sleep, medications, beta blockers, calcium channel blockers. So how do you treat it? Well, you treat it only if the patient is symptomatic. And symptomatic meaning they're short of breath, their blood pressure is low, altered mental status, chest pain, dizzy, fainting. If they're symptomatic, we want to give them oxygen, and we would like to give them atropine. Okay, and you'll go over this more hopefully in ACLS, and I'm kind of curious what that's going to look like. That, yeah, I have to talk to Justin about that. Atropine, usually about 0.5 milligram to 1 milligram, so 0.5 to 1 milligram, with a maximum of 3 milligrams. Okay, so you can repeat it, but you don't want to go over 3. And possibly an external pacer if they're, nothing has turned around, and trying to figure out the cause. Why are they bradycardic? Okay, maybe they just need a little bit of, maybe they're cold too, maybe just a little bit of fluid. Who knows? Checking their blood pressure, especially if their blood pressure is low. All right, just another picture of sinus Brady, what it can look like. All right, moving on to sinus tach. I gotta love working from home. My son just threw a package in my office here. That came from Amazon, I guess. How do you know you're supposed to throw that? I didn't know. All right. Okay, so sinus tach. So we're looking again, generally over 100 to 150. It's regular. We do have P waves. They're normal looking, followed by QRS. QRS is usually, again, less than 0.12, sometimes a little bit narrower. So what are the causes of tachycardia? Hypovolemia, so they could be dry. Okay. I was just thinking about bradycardia sometimes. If you have low volume, possibly. That's just another thing to consider, especially if their blood pressure is not good. Most people can give at least a half a liter, if not a liter of fluid, and tolerate it fairly well. I hope my microphone, oh goodness, there it is, can tolerate a liter of fluid fairly well, especially in this elevation when it's dry. But if you're a renal disease or CHF or something, you got to be a little careful. All right, so some of the causes of hypovolemia are, of tachycardia are hypovolemia, hypotension, sepsis, fever, okay, we should know that, heart failure, CHF, MI, drugs, fear, stress, any type of stimulants, pain, exercise, okay, and we should be worried about this because it can increase our oxygen demands It can decrease cardiac output, decrease blood pressure, decrease filling time, decrease coronary artery perfusion. So these are things that we need to look at, okay? Consider, are they symptomatic? If they're asymptomatic, you might just be able to observe them. Again, trying to figure out the cause, okay? Treat the underlying condition. If they are symptomatic, again, that's treating the underlying cause. Beta blockers might help bring them down. Oxygen, calcium channel blockers, okay? This heart rate's approximately 120. Okay, so here is another view of sinus tach, just another example. All right, moving on to sinus dysrhythmias. Okay, so sinus dysrhythmias. So meets all criteria for a normal sinus rhythm, but it's irregular. Okay, so the rate's going to be about 60 to 100. It could be maybe a little on the bradycardic side. The rhythm is going to be irregular. Your P waves are normal, and you have each of them follow the QRS. Your P to R interval is within normal range. Your QRS is normal. So these could be rhythm changes that could be associated with respirations. So when your heart rate will go up with inhalation, it can go down with exhalation. It's more common in children and young adults, and it's generally asymptomatic, so it's nothing to get too terribly concerned about, unless you become symptomatic. All right, moving on to abnormal atrial rhythms. Okay, so one of the first ones we're going to talk about is a PAC. Okay, so premature atrial complex. Okay, when I was having my little issues several years ago, where I was feeling these like extra beats, it's basically kind of an extra beat or more like a pause than anything. And then the re-entry part kind of is what was uncomfortable with it. I wore a Holter monitor for, I don't know, 24 hours or whatever it was, and that was what they saw, was like PACs more than anything. And it was just like the kind of the little pause and the next beat, and it was just uncomfortable. It was more annoying. I didn't feel lightheaded or anything like that. It was just uncomfortable. So these are generally benign. It shows up earlier than the next expected beat. The rate is typically normal. The underlying rhythm is typically regular with premature early beats. The P wave is, the atrial depolarization is coming a little premature, occurring before the next normal P wave. So the impulse originates outside the SA node, and the P wave may have a different shape, often notched, peaked, or buried in the preceding T wave. It usually comes from an ectopic stimulus that arrives from either the left or right atrium, but not the sinus node. So here are some examples of a few PACs. Sometimes you can get a pair of them. Sometimes it could be a bigeminy, it could be an actual pattern where it's every other beat, or a trigeminy every third beat, or more frequent, more than 6 beats a minute. And I was having them more frequently at one point, the time where they really bothered me, when I was at work and I went down to the ER, and it was just that my heart rate was high and my blood pressure was high. I think it was more stress than anything, but the more often a PAC shows up, the more irritable the heart is. Alright, so some of the different causes are some of the ones listed here, along with pregnancy, stress or fatigue, hypertension, heart disease, smoking, dehydration. Okay. Ironically enough, it seemed like the beta blocker definitely seemed to help it too. So I'm on a low dose beta blocker, but Also trying to cut out caffeine, alcohol, possibly needing oxygen or Lasix. So if they're symptomatic, you want to treat them, but generally their occasional PAC really doesn't hurt anything. Okay. The only concern is that if you have an increased number, it may be a forerunner of the development of AFib or any other atrial dysrhythmia. This is me. Coffee is my drug of choice. All right. A flutter. All right. A flutter is that rapid sawtooth pattern. This happens when the atria become irritated, which initiates several electrical impulses. The AV node then must take over and control the number of impulses that go through. So not every atrial depolarization is going to go through to lead to a ventricular one. So that's where you kind of have that. You end up getting those different ratios. We'll talk about that here in a minute, where you have like a 3-to-1. So you have like 3 atrial beads and then 1 QRS. So you have like, and then, or 2-to-1 or whatever. So the AV node, not the SA node, is going to control the heart rate. It's basically a result of flawed re-entry current within the atria. In the setting of a flutter, coordinated contraction of the atria is absent. Okay, so we have to be concerned whether or not the patient has a sufficient cardiac output. Monitoring their blood pressure is huge, because they've kind of lost their atrial kick. Okay, so here's another example of what atrial flutter looks like. A lot of times the atrial rate's about like 250 to 300. The ventricular rate is variable depending on the slow or fast ventricular response. So the flutter wave should not actually be confused with P waves. So there's I've read a couple different things where these really aren't P waves, more of like a flutter wave. Okay. The AV node is a wonderful protective mechanism. So think of how the atria are depolarizing, though, at a rate of 250 to 350, up to 350 sometimes. So if all these atrial depolarizations were conducted down to the ventricles would most likely start to fibrillate. Okay, so they're helping protect it. So think of the AV node as the central train station where numerous tracks merge. The central station only allows some of the trains to go through to avoid congestion. Okay, so when the ventricular rate is less than 100, it's considered a controlled atrial flutter. But if your ventricular rate happens to go over 100, then it's considered an uncontrolled rate. Okay, so again, looking at the rate of the ventricles and also looking at your patient to see how their fill time. All right, so this is that ratio I was talking about. So you could have like a 2-to-1, a 3-to-1, a 4-to-1. So that's like every other atrial contraction gets through. If it's a 3-to-1, every third atrial contraction gets through, and so on. All right. So back to talking about, I clicked a little bit too fast. I wanted to continue, as I'm continuing talking about atrial flutter, and some of these are actually the same for AFib too, but so again, atrial flutter, so don't look at your screen right now, just write down back on your atrial flutter slide if you have your notes. Some of the causes can be an MI, right heart failure, mitral or tricuspid valve disorder, hypoxia, digitoxicity, CHF, SA node disease, PE, alcoholism, hyperthyroidism, post-cardiac surgery, and pericarditis. So these could be all causes of A flutter. I'll say it again. Right heart failure, mitral or tricuspid valve disorder, an MI, hypoxia, digitoxicity, CHF, SA node disease, a PE, post-cardiac surgery, pericarditis, alcoholism, and hyperthyroidism. So how would you treat it? Oxygen. If rapid A flutter and unstable, you might need to cardiovert them. Okay, so if you cardiovert them, you're going to cardiovert them at 100 to 200 monophasic joules. Okay, so cardiovert for unstable, 100 to 200 monophasic joules. You also want to treat these patients with blood thinners because they can, their blood can pool, and that's especially true with AFib. So we're definitely checking blood pressure. Okay, so AFib, that is characterized by this chaotic baseline between the QRS complex. Okay, so you just have like these squigglies in between the QRS complexes. Your rate can be variable, your rhythm is irregularly irregular, your P waves are like fibrillatory waves that all vary. You do not have a measurable P to R, and your QRSs are less than 0.12. So again, your atrial rate can be anywhere from 350 to even 450. So even higher than AFib. So basically your atria are quivering. The atria have no pumping ability. The AV node will take over but cannot handle all the activity. It will allow random contractions to pass through in no particular order or rhythm. So that's why the QRSs just kind of pop up whenever they can. Cardiac output is reduced with the loss of the atrial kick since the atria are really not contracting. So there is no organized electrical activity, which means ineffective pumping of the atria. Typically easily to diagnose due to the irregular occurrence of QRS complexes. So we're on the AFib. QRSs are a little bit more regular. I mean A flutter, sorry, A flutter. Okay, again, it can be acute or chronic. There's a lot of patients that have AFib that we see. A lot of our CHF patients, COPD patients, patients that have had open heart surgery. It's not at all common for them to go into AFib because the heart is irritated and it's been messed with. It's annoyed, so it may sometimes go into AFib. Coronary artery disease, mitral valve disease. Acutely, we need to look to see if they're having an MI, if there's some ischemia, if there's hypoxia, digitalis toxicity. So you can always assess your patient, checking their blood pressure. So if they're unstable, okay, we need to consider cardioversion. Okay, again, with this one we would do biphasic. Okay, so we would do biphasic. So the meds that we would consider are beta blocker, calcium channel blocker, amiodarone, also oxygen, possible digitalis, and propranolol. So this can lead to an MI or ischemia. Also, don't forget your blood thinners. So I just want to talk a little bit about monophasic and biphasic, okay, kind of what the difference is. So they like to use biphasic generally because you can use it at lower joules. it's considered just as effective as high energy monophasic. So if you do a biphasic at 200, it's just as effective as a monophasic at 360 joules. However, there's less damage to the myocardium and you have less incidence of skin burns if you use the biphasic. So the biphasic, basically the current is delivered in two directions, where the monophasic is just delivered in one direction. Alright, so here's just a quick look of the comparison of your A-flutter and your A-fib, where you can see that your QRSs are a little more regular on the A-flutter, and where the A-fib you just have the kind of more of a squiggly, sometimes it's even a finer line, and your QRSs just occur randomly. So just another side note about defibrillation versus cardioversion. Okay, you only defib a patient when they're pulseless. Okay, so you don't feel a pulse, no pulse, then you defib. Okay, you cardiovert, and that needs to be synchronized with the heartbeat. So it's synchronized cardioversion. Okay, if the shock is done out of synchrony, you can actually send the patient into systole. So you want to make sure you're doing synchronized cardioversion. So it's going to come in where it needs to. All right, SVT. We're going to talk a few more slides. Wow, this is a long one. Sorry, guys. I hope this thing uploads. SVT, supraventricular tachycardia. So that's a tachycardia that originates above the ventricles. Okay, so there's a rapid atrial ectopic focus that actually overrides the SA node, and then that becomes the primary pacemaker. So the SA node's not in charge, it's something else that's in charge, but it is above the ventricles, so supraventricular. Okay, so it does not originate from the SA node. The P waves are visible. The rhythm may be called atrial tachycardia 2 also. If no P waves are visible due to a very fast rate, then it is SVT. Okay. Sometimes you'll hear it referred to paroxysmal VTAC, which means it just appears suddenly, just like a sudden onset, but at the same time it can disappear suddenly. So it just kind of comes on and then it goes away. Okay. So it either speeds up or slows down suddenly. So the onset of PSVT or PAT, paroxysmal atrial tachycardia, is typically abrupt, with the onset being initiated by a premature atrial beat. The arrhythmia may self-terminate in a few minutes to within a few hours. So again, you need to continue to monitor your patient. So here's some different examples of what SVT can look like. Some of the different treatment maneuvers. They may have the patient do a vagal maneuver where they cough or bear down, squat, cold water, kind of sometimes even you'll see them bending up their knees and have them kind of push, like bear down. Adenosine, if you've seen that work, that's pretty awesome. It causes basically a total AV block, and then the heart should hopefully returns. It should be a normal rhythm, keeping your fingers crossed. So I've seen that done before at Lutheran several years ago, where the lady went to a whole length of a screen, flat line. We're all like holding our breath, and then she came back to normal sinus rhythm. If they're unstable, so if they're deteriorating, they don't have blood pressure, altered mental status, whatever, consider cardioversion. So some of the causes can be rheumatic heart disease. It's usually a mitral valve issue, arteriosclerotic cardiovascular disease, overexertion, stress, hypoxia, stimulants, hypokalemia, and meth. Okay, so you may see patients come in with this. All the lovely street drugs out there. All right, just you can also give beta blockers, verapamil, and DIG. All right, so again, an EKG is kind of providing us A picture of what's going on with the heart can help identify different conditions, ways how we're going to treat, can identify abnormal arrhythmias, but it does not measure the pumping ability of the heart. Okay, 55 minutes. Whew, I hope this works. All right, guys, we'll talk next time.